Okay, any questions? Final part of it?
Related to this week's, the second this week's folder.
Uh-huh.
There's like 4 PowerPoints, 2 of them.
Oh,
Are
that's good.
they different? Like there's 2 different sets. Are they the same, or and they just different formats, or are they like different?
I don't know.
Because one says by Professor Harriman, so I didn't know if there's extra stuff on that one that we should like be going through that one instead of the other one.
Alright, what is it?
Because the objectives are different too.
So you're just gonna go by mine. They're pretty much the same. I just since I'm new, I'm reading everything you guys are reading and trying to go through everything and refreshing my memory. So
Was that just put on there like just now?
no, I uploaded it I think Wednesday.
Because it's not showing up on mine.
So hers are there to have for you guys, and then mine are just mine, similar.
It's not showing up on mine.
Oh, these ones.
Oh, it doesn't look the same on.
I
Okay.
colored mine to make them stand out.
Gotcha.
So you're
So-
gonna be using the one that they buy Professor Harriman.
Yeah, she's
Yeah.
using her lectures, yeah. It's really, like, lectures are very personal. Like, I don't, like, if you ever get the opportunity to, like, be an educator, it's really, like, you can't lecture from someone else's. It's very weird. Like, you'll be like, like, it's just, like, you need to do it in your brain in the way that your brain kind of organizes it. So it's really gotta be.
Yeah.
So, yes, I get you that
We
it's,
just wanna make sure we're taking notes, like, and going through. She's
Yeah,
going through, I think, so.
yes, absolutely.
you.
All right. Any other questions? All right. I know there was a couple emails I got over the weekend. I honestly don't have time. I'll be perfectly honest. I'm running kids, but I did look at them long enough to be like, this could wait till Monday, kind of thing. You know, if I needed to respond to somebody in the moment, I will do it. So I'm gonna respond to some emails. So don't be surprised if you did email me and they pop up responses while you're in lecture. But I'll be here.
Oh my god,
Do you want to change it to the extended? I did. That's still on the duplicate view. If you wanted to change it to the extended view. Okie dokie.
Do you guys feel ready for this next exam? How do you guys?
no.
Okay, well, if you guys do need help, just come to me during office hours, make an appointment. I'm available for you guys. So in this presentation, we're going to do 2 separate presentations. We're going to do seizures, epilepsy, and headaches. So a seizure is a single event of abnormal activity, whereas epilepsy is chronic recurrent seizures. This is an actual diagnostic condition. So we'll go over these. Again, I want to emphasize the objectives are your study guide on the test. Every question will come out of the objectives. So seizures. Has anyone witnessed seizures, whether in your personal life or in the hospital? Has anyone had? Okay. So they are sudden temporary disruptions in brain function caused by abnormal electrical discharges from all the chemical changes in the brain cells. So these discharges may affect a part or all of the brain. And then that term ictal, that just refers to specifically to the seizure event in progress. So epilepsy is diagnosed when a person has those recurrent and provoked seizures or meets criteria for a certain epilepsy syndrome. So to diagnose, you have to have 2 or more unprovoked seizures over 24 hours apart. 1 unprovoked seizure with a high risk of recurrence, or a confirmed epilepsy syndrome, which we won't get into too much detail with those syndromes. But epilepsy syndromes are defined by patterns such as the age of onset, family history, and types of seizures. So I actually had my best friend in middle school. I lost contact with her. She had moved, and just last year I found out through her sister that she had died. In her recent years, she was in her late 20s. She had been diagnosed with epilepsy, and she just had a seizure as she was driving. So this is something that you can be diagnosed later on in life. I didn't realize that. I always thought it was like something at childhood or in your younger years, but you can be older and diagnosed with epilepsy. So status epilepticus, this is an emergency. So this involves a continuous seizure, activity lasting more than 5 minutes, or multiple seizures without full recovery of consciousness between them. So seizures lasting over 5 minutes often require medical intervention to stop. I think the longest patient season I have was 10 minutes in the ER. We gave like 4 rounds of Ativan. But usually they are, the most I've seen have been under 5 minutes.
Is that what was on our peds? 5 minutes? I feel like she said like half hour.
For peds.
Yeah.
You have to watch a kid seize for half an hour?
That's what she said. I'm pretty sure. Is that what she said?
I've never seen kids seize for that long. I've seen frequent seizures, but not like, it can happen, I'm sure, but.
Oh, good. I'll just remember 2 different things at the same time. Beautiful.
So,
Status epilepticus in pediatrics is 30 minutes?
That's what she said.
That sounds.
Well, she said, well, yeah, you did.
Yeah, she did.
Can you imagine watching kids seize for 30 minutes?
I said 10 minutes. She said.
Clonic was considered at least 5 minutes or something like that.
Yeah, I don't know.
No, my clock was like 10 seconds at a time.
Yeah, yeah, 10 seconds in one phase and a couple minutes in the other.
It could last up to 30 minutes.
okay.
And then at that point, it would be considered.
No, I'll pull it up. Because it's kind of.
Yeah.
No, we try and fix it real quick with the phones.
Yeah.
Maybe kids are more resilient or the pause is not. I don't know.
What the hell week was that?
That's awful.
Yeah.
Sorry, we totally got off.
That's okay. Yeah. So, what are the pathophysiology of seizures? So, the pathophysiology is that these neurons in the brain carry messages using bursts of electrical energy to perform tasks in our bodies. So, sometimes the brain cells keep firing after this task is done, causing erratic or uncontrolled body movements due to these extra firing signals. So seizures happen when the brain's electrical balance is disrupted. 3 conditions must actually be present. So either the excitable neurons, these excitable neurons are ready to fire, too much excitatory activity, especially involving glutamate, which spreads signals rapidly through the brain, and then either too little what they call inhibitory control, mainly from GABA. And what is GABA? That is the brain's main calming chemical, which normally calms the brain down. So it's either too much go and not enough stop, and the brain causes neurons to misfire. This is what triggers a seizure. So anyone can experience a seizure depending on the individual neurological threshold. So everyone's brain works differently. So again, seizures result from an imbalance in the brain activity. Either the brain is sending those too many go messages and not enough slow down or stop messages. Approximately about 10% of Americans have seizures at some point in their lives. So types of seizures, partial, so simple partial also similar to focal. I guess they used to call focal seizures partial, and now the modern term is focal seizures. So there's simple partial, which is partial focal, complex partial, and then generalized seizures. So there's three main types of seizures. So focal seizures begin in a specific area of one brain hemisphere, often the temporal or frontal lobe, so it's only in that one specific part of the brain. Whereas generalized seizures involve both hemispheres simultaneously, causing widespread brain activity from the start. So the two types of focal seizures, so there's focal seizures with retained awareness. That is when the person stays conscious, so they may have body movements, they might experience an aura, similar to, again, these are similar to simple partial seizures. And then focal seizures is with altered awareness, altered loss of consciousness. So that is when consciousness is impaired, resembling complex partial seizures. So the activity can spread to both brain hemispheres, and these complex seizures, the person does not remember anything. And the third category is generalized seizures. So these affect both brain hemispheres, causing full body reactions. So they may have tonic-clonic movements, which is complete body stiffening followed by that rhythmic jerking. They may have epileptic cry, which is caused by chest and diaphragm contractions. Possible tongue or cheek biting, loss of bladder, bowel control. Usually after 1 to 2 minutes, the movement stops and the person may enter a deep, noisy breathing coma. In that post-ictal phase, after the seizure has completed, the patient usually experiences confusion, sleepiness, headache, sore muscles, weakness, fatigue, and depression are common. So out of the 3 types of seizures, there are 6 seizure descriptions of what the seizures could actually look like. So a person may show different descriptions of seizures. There's tonic-clonic seizure. Again, that starts with body stiffening, which is that tonic-clonic phase, followed by full body jerking movements, which is clonic. So they used to call these, when I was in school, I learned the grand mal. The tonic-clonic is actually a newer, modern term for grand mal seizures. It's just more specific to that, what the seizures are actually are. So they're the same thing as grand mal. Clonic seizure is that repetitive jerking of muscles on both sides of the body. Absence seizures are brief staring spells with loss of awareness. A tonic seizure is sudden loss of muscle tone, causing a quick collapse or drop to the ground. And myoclonic seizures are very quick, shock-like jerks of a muscle or group without losing consciousness. To remember the difference of first tonic-clonic, I like to think of tonic equals tight and clonic equals convulsions to describe the two. I remember when I was a brand new nurse, my first seizure patient was an absence seizure. I had never seen that before, but she was just, her eyes were open, laying in bed, staring at the ceiling for at least 2 minutes, unresponsive, and then when she snapped out of it, she was very confused, didn't know where she was, what was going on. So it's super interesting to see an absence seizure. So what are the causes and risk factors for seizures? So there's acquired risk factors, and then there's the idiopathic, which is genetic and developmental defects. You guys do need to know all of these risk factors for seizures. So acquired seizures can result from various conditions, external factors such as brain issues, strokes, head injuries, brain tumors, even Alzheimer's disease can cause seizures. People with oxygenation problems, so hypoxemia, poor blood flow, poor circulation. Infections, do cause seizures, especially in the central nervous system. Metabolic imbalances such as kidney failure, low sodium levels, low calciums, and then low blood sugar levels. That's why a lot of times when people seize, you want to get that blood sugar right away. Toxins such as pesticide exposures, drug toxicities have been known to cause seizures. People withdrawing from alcohol and drugs, definitely seizure risk. And then other triggers are high fevers in children, high blood pressure, and allergies. I'll never forget my first seizing baby when I was a nurse in the ER. She was 6 months old. Severe infection, high fever. She was seizing the entire shift till we transported her to a children's hospital. The parents were screaming and crying every time. It was just a crazy, crazy situation to see. But that's just one patient I'll never forget. It was my seizing baby. And then notice how genetics is not a risk factor for acquired. It's just idiopathic is the genetic and developmental defects.
I thought idiopathic meant that they don't know how a thing
Yeah,
happens.
idiopathic is usually just happens spontaneously, but I guess they're just breaking it. The book is breaking it down into those two categories. So idiopathic can be because of genetic or.
But is that usually what that means? I just want to make sure I have the understanding of the word right.
That's usually what idiopathic is.
Okay.
Yeah, that's just that's how the book broke the two categories down. And I was gonna watch this video. Oh my gosh. Has anyone seen the dogs that help their owners with seizures?
Yeah, they're cool.
Pretty interesting.
Dogs are so good. We don't deserve them.
It's just something that I thought was cool.
After suffering a seizure in a grocery store, is home safe tonight after suffering a seizure in a grocery store in Winston-Salem.
And she has her service dog and the store's assistant manager to thank for that. WXI 12 Joshua Davis reports in this 12 Inspires.
Amber Laudacita was training her service dog at a grocery store when that training kicked in, and it was all caught on camera.
You cannot train a dog to alert to seizures. They either detect it or they don't.
Amber Laudacita was at Harris Teeter in Winston-Salem, recording this video of a training session with her dog, Coda. After a few minutes of training, Coda barks and then lies down, ignoring Amber's training commands.
When I have my pseudo seizures, it's not epileptic, so I actually don't know when they're coming on. I can't feel it when it's coming on. You can see in the video where you'll start to recognize I'm dazing off. I'm starting to lose mobility. I start to lose my ability to speak.
Amber tried to continue with the training until she says she realized she felt a bit off, and she takes a seat. Coda stays with Amber as people pass by. And that's when the store's assistant manager walks up to help.
The employees typically don't sit with me or anything like that. They tend to just stand around and wait for EMTs to arrive. She pulled out all the stops for as long as I have had service dogs and as long as I have actually been sick. I have never experienced someone take on a situation like she did.
The assistant manager stayed with Amber as EMS came to check on her. Thankfully, she didn't need to go to the hospital. And Amber says she hopes her experience encourages people to be compassionate when they see others in need of help. In Winston-Salem, Joshua Davis, WXII 12 News.
That's so cool.
Why has no one ever told you that the active compound in honey can actually reverse cognitive decline and brain fog?
Okay.
Yeah, I've seen videos of dogs like laying down on the ground, protecting the owner when they fall, which is pretty insane to watch too.
Man, we got to go to the dementia facility and just give everybody honey.
I know. So when we have seizure patients, we do gotta take a look at their medical history. So we're gonna assess what their seizure history is, because we want to be prepared for these patients. Are they on substance abuse? Certain medications can actually cause seizures as well. Family history, prior brain impacting illnesses or injuries. So female-specific factors, females can actually have increased seizures during menses. We need to be aware that pregnancy patients with seizures that are pregnant, a lot of these medications can cause fetal anomalies, so we need to take that into consideration. Triggers, we need to know what are your triggers. What's the patient's triggers, such as sensory, odors, flashing lights, certain music can cause seizures. Patients that are fatigued, that are not sleeping, so anyone that's not sleeping enough, that can trigger their seizures to happen. Low blood sugars, emotional stress, fever, alcohol, excessive water intake, constipation are all risks for seizures in these patients. Another thing that I read in the book was noted is that the nurse also needs to be educated and aware that transgender patients' medications interact with epilepsy medications. So gender-affirming home therapies, especially estrogen, can lower levels of anti-seizure medications like lamotrigine, increasing the seizure risk in these patients. And a lot of these patients may withhold medication details due to fear or stigma and judgment from providers. So it is our responsibility as nurses to use inclusive language and foster a respectful, non-judgmental environment and recognize how gender identity intersects with epilepsy management. Super interesting. I didn't know this, but Johns Hopkins was the first hospital in the United States that performed gender assignment surgeries, and they recently opened their clinic back in 2022, because I guess it was closed for a little while. That's interesting that it's literally right in our area. I thought that was pretty cool.
What did you say they did?
They were the first in the United States to do gender assignment surgeries, transgender surgeries at Johns Hopkins, yeah. So diagnostics, how are we diagnosing seizures? What is the workup we need to do for people having seizures? So these include clinical evaluations such as physical and neurologic assessments, multiple lab tests, including biochemical, serologic studies. The main diagnostic tools that we use, and especially in the hospital, are EEGs, MRIs, PET scans. And these assess brain function by looking at electrical and metabolic activity. There is the SPECT. The SPECT scan means single photon emission computed tomography. These identify the seizure generating zone for potential surgical removal. So SPECTs are done on patients who are possibly going to have surgery. EEG is the most significant diagnostic study that we use for seizure patients. It provides diagnostic evidence and helps classify the seizure types.
Is that the thing that they wear?
The
like they stay in the hospital and okay.
Mm-hmm. So there's EEGs that can be a one-time, that can take only an hour, and then there's the EEGs that are more advanced, continuous EEG monitoring. So the continuous video EEG telemetry combines video and EEG to assess seizure types, duration, and intensity. So this is what you see in the hospital, the EEGs. So again, the EEG provides key diagnostic evidence and helps classify the seizure types. So abnormal EEG patterns may persist between seizures or be triggered by sleep deprivation or hyperventilation. These depth electrodes can record activity from the individual brain cells. There are some limitations. Sometimes it may not be completely accurate when doing EEGs. Some patients with seizures may actually have normal EEGs, and then the opposite, conversely, some without seizures may show abnormal EEGs. So sometimes it's inaccurate, but majority of the time it is pretty accurate. So how are we managing seizures as a nurse? So as nurses, we need to stop the seizure as soon as possible by ensuring adequate cerebral oxygenation to that brain, maintaining the patient's airway, applying oxygen, and then having suction and suctioning as needed. So in status epilepticus, we use the ABCs, airway, breathing, and circulation. They are the immediate priorities in emergency management to stabilize the patient. So this involves securing the airway, administering 100% oxygen if needed, supporting circulation with IV access, blood pressure management, and also checking and correcting low blood sugars.
How do they push the meds if they're in like actively seizing? Do you just wait for a tonic
You can push
phase?
it. You can push it.
But like, how do you get it hooked up if they're? That's what I'm asking.
You can still just grab their arm and have someone.
Oh, okay.
I mean, briefly.
So it's okay to stabilize for just a quick second to do that.
So when I had an active seizing patient before, like in the ER, they're moving around. I mean, I guess they weren't like
Right.
crazy moving, but
Right.
it wasn't an issue.
Okay.
Pushing the meds, yeah.
Cool.
So if they don't have an IV, you just do an IM injection of it?
Yeah, so you can do
Okay.
IM, IO. That's like the last resort.
Oh yeah, those are.
But I've never had it to the point where we couldn't get IV access.
Like during?
Yeah.
Really? Oh, okay.
That's gangster.
Huh.
But I was only an ER nurse for 1 year, so. But in my 1 year experience, we never had issues getting access. So here's a pretty informative video on status epilepticus. I know for me, the videos help me retain that long-term memory. And why is my edit? Oh. This is actually for med students, but same thing.
Status epilepticus is defined as continuous seizing for more than 5 minutes or back-to-back seizing without awakening. It is a medical emergency and something that you must know how to treat. When you're called to see a patient who's actively seizing, it is important that you yourself stay calm and have an organized plan of action. Do not wait around for the seizure to stop spontaneously. The longer a patient seizes, the harder it is to stop, as electrical short circuits start forming in the brain and make it much more difficult to suppress. As in all emergencies, the ABCs, or airway, breathing, and circulation, take priority. Place the patient on 100% oxygen, attach him to the monitors, and establish intravenous access. Check a blood sugar and correct it if it's low. The first line medications to stop the seizures are benzodiazepines, and they can be given repeatedly every 5 minutes until the seizure stops. If you are lucky to have an intravenous line established, Ativan or lorazepam is your drug of choice. If you do not have an IV line, you can give Versed or midazolam intramuscularly or intranasally. Rectal Valium or diazepam is an alternative option. If you do not have IV access after a few doses of benzos, then an intraosseous line, often placed in the tibia, should be inserted, as it allows quick penetration of additional drugs. After benzodiazepines, dilantin or phenytoin should be administered, as an infusion. Remember, never push dilantin as a bolus, as it will cause life-threatening apnea, hypotension, and arrhythmias. If the patient is still seizing, intravenous phenobarbital or valproic acid can be given over 20 minutes as a second-line agent. The final step in the treatment of status epilepticus is general anesthesia with intubation and EEG monitoring. The most common causes of status epilepticus are non-compliance or discontinuation of anti-epileptic medications. However, alcohol and drug toxicity or withdrawal, CNS infections, CNS malignancies, and severe head trauma must all be ruled out. In the back of my mind, I also consider these three other causes in select patients. Number one, could the patient be pregnant or postpartum? If yes, consider eclampsia and check the blood pressure. And if present, treat with intravenous magnesium sulfate and urgent C-section if still pregnant. Number two, could this be an overdose of the TB medication INH or isoniazid? This type of overdose can present with intractable seizures and will only respond to intravenous vitamin B6. And finally, could this be a form of hyponatremia? If the patient has a sodium of less than 110 and is actively seizing, you must correct the sodium, but not too fast because that can cause brain edema.
It's pretty quick and informative.
Mm-hmm.
Okay.
Watch what magnesium does to your bowels.
If you have to wipe more than 4 times after...
So, how are we managing as a nurse these patients during seizure?
Pad the bed, protect the environment, manage the airway, suction if need be.
So, first thing is we do want to provide privacy if possible. Patients having seizures, it is something we do want to try to give people away so there's no onlookers, shield the patient from onlookers. Excuse me. If R is present, we want them to reach a safe private space before they're seizing. So it's not every patient has RAs, a lot do, which is that warning sign. Thankfully they have that, so it does warn them to be prepared to have that seizure. So immediate actions are to, if the patient's not in bed, to slowly ease them to the floor and protect the head with padding. I had a coworker whose patient was just walking to the bathroom and did all of a sudden have seizure, fell to the ground, hit his head. He ended up in the ICU. I don't know, it wasn't my patient, but I think he might have had a stroke because of it. So that is a huge priority, is to get that patient safely to the ground if we're able to. We're gonna, once the patient is on the ground, we're gonna again protect the head with padding, loosen tight clothing, remove eyeglasses, clear nearby furniture to prevent injury. If in bed, we're gonna remove those extra pillows to prevent suffocation, raise those side rails. Hopefully they would be padded if they are already known seizure patient. Avoid harmful intervention, so we're not forcing jaws open or inserting objects because that's a risk for breaking their teeth or cause oral injury. So I think back in the day there was a myth saying that seizing patients could swallow their tongue or like choke from their tongue, but that's not true. That's a myth. So I think to this day people think, oh, we need to put a tongue depressor. Do not do that. Put nothing in the mouth. Do not restrain the patient, or patient's muscle contractions may cause injury. We're going to provide airway support. So we should turn the patient on their side as soon as possible. During a seizure, to keep their airway open, prevent them from choking on vomit, to aid in saliva or mucus drainage, and then have suction ready to suction them as needed. This is just a super short clip of for seizure management. If I can put it. I wish we could just play videos on the PowerPoint. I don't know why it won't let us. Why is it not letting me play it? Okay. Now it's frozen. Okay, I guess this is not gonna work. It's not letting me go back.
Maybe press pop out this video.
Pop out. Okay, never mind. It's just it goes over Sonar for seizure patients, but this is not working. Okay.
Is the link in the PowerPoint that they have access to?
Yeah.
So you guys could watch it on your own.
It's like a TikTok. I don't even have TikTok, but I guess it's TikTok, so maybe that's why. Okay, sorry about that. So after seizure, how are we caring for the patient post-ictal? So after their seizure. So priority, you guys need to know this. Assess respiratory status. So the priority nursing care after seizure is to assess respiratory status. So again, we're going to have that patient position in the recovery position on their side to prevent aspiration. Ensure the patient's airway remains open and clear. Again, suctioning, providing oxygen as needed after their seizure. We're going to expect confusion, especially after tonic-clonic seizures. They may not know, they're not going to know what happened. They're not going to know what's going on. They may not even know where they are until they're reoriented. It depends on the patient. Sometimes it can take hours for the patients to snap back out of it because they can be very drowsy and confused for a few hours, I've witnessed in some patients. So brief apnea may occur during or after generalized seizures. We need to assess vital signs and blood sugar levels if it's related to that low blood sugar level. So we're going to reorient the patients upon wakening using calm, reassuring communication, especially if post-ictal agitation occurs. I've never seen the agitation, but I'm aware that it can happen. The patient's bed remains in low positions at all times with padded rails up. So which of these interventions would be okay for a unlicensed assistive personnel to do?
Clear the room.
Clear the room?
Oh, we're talking about the after part now.
So what can the
Maintain privacy, reorient the patient.
CNA or tech do?
Blood sugar vitals?
Yes, blood sugar, vitals. They're gonna also it's as a nurse, it's our priority to make sure beds in low position, bed side rails. They can help pad side rails and help maintain privacy. But yes, blood sugar levels and vitals. So seizure precautions, you guys need to know this entire slide. Know these seizure precautions inside and out. So what are you going to do if you have a patient that's going to come into your unit that's a seizure patient? What are the biggest steps that you're going to do for your admission before they get to the unit?
Pad the bed rails.
Yes, so you're going to always pad the bed rails. A lot of times hospitals won't have enough the specific seizure pads. So what you can do is you get blankets, tape the blankets down, use whatever clever things. Sometimes I use the little underwears, the disposable underwears to tie them down. Make sure their IV is patent right when they get to the unit or start an IV. Suction setup, always have it ready to go. Make sure the suction's working. Make sure the oxygen setup, the oxygen's working. Do not allow patients to ambulate alone when they get to your unit. They need to be with someone at all times. Ensure that call bell is always in reach and keep that bed in the lowest position. So seizure precautions in the home, just something to be familiar with. It's important that when we're discharging our patients to be educating them on this, because 50% of all epilepsy patients do die from preventable accidents such as drowning, trauma, burns, or choking. So we need to educate on seizure-safe practices in the home setting. Some education we can provide is avoid swimming alone, choose showers over baths, and steer clear of high-risk activities that can cause injury during a seizure. So pharmacology, so many medications are available to control seizures, but as nurses we need to educate that treatment is not curative. So what is the goal for our patients with the medications? Our goal is to control seizures with minimal side effects as much as possible. So the medication strategy is chosen based on seizure type. So seizure type, safety, and then effectiveness. So proper use of medications control seizures in 70 to 80% of patients. So the other 20 to 30%, these drugs don't actually work. There are drug-resistant issues and some patients taking these seizure medications. So about 35% of epilepsy patients are resistant to the anti-epileptic drugs. For these individuals, surgery may reduce or eliminate the seizures. The most common that we see given for seizures right away is those benzodiazepines. There are a lot of adverse effects with benzodiazepines that we need to be aware of and monitor. These include respiratory depression, respiratory arrest, drowsiness, confusion. So what do we get for these patients that are having these adverse effects of benzodiazepines? What do we get for these patients? Yes, I heard flumazenil. So this is the reversal agent for benzodiazepines if you need to give it. You guys need to know that. So question for you guys, what intervention does the nurse implement if patients experience the side effects of the benzodiazepines? What are we implementing as a nurse?
ABCs.
So what goes with the ABCs? What are we gonna do?
Oxygen, put pads on them preemptively.
So the main, those are all right, but the main interventions that you guys need to know if you get a test question, we're gonna assess oxygen and pulse oximetry, administer oxygen as needed, and administer that flumazenil. So common anti-epileptic medications that you'll most likely see very common in the hospital are Keppra, Dilantin, and phenobarbital. So many anti-seizure medications are also known to reduce bone mineral density and cause a higher risk for fractures. So we need to, these patients are already going to be fall risk patients, but even more so if they're on these medications. The doctors will probably recommend calcium and vitamin D supplements for your patients taking these anti-epileptic medications. Also, some anti-seizure medications generally require routine labs, especially those older generation drugs such as phenytoin, valproic acid, and carbamazepine, which is also known as Tegretol. So if you're giving these medications in the hospital, you'd need to double check those lab orders because you want to make sure the labs are done before you give the medications to make sure the blood levels are therapeutic. This is just a chart in your book for common anti-seizure medications. Again, these medications control 70 to 80% of seizures. These are all, I kind of broke it down for what I've seen working in on epilepsy units in general. So all these meds I have given as a nurse in the hospital. So just you need to be familiar with them. Surgical management. So surgical treatment for epilepsy may be needed when epilepsy is caused by brain tumors, abscesses, cyst or vascular anomalies, intractable seizures that are unresponsive to medications, and impaired focal brain function due to trauma of that brain, inflammation, strokes, or anoxia. So if seizures stem from a well-defined brain region, A lobectomy is done, and what a lobectomy is, it's surgical removal of that specific area of the brain. This offers long-term seizure control without major neurological deficits. The other surgical option is called vagal nerve stimulation, and this is used alongside medication in adolescents or adults. So not children, but adolescents and adults that have focal seizures. This is where a device is implanted under the clavicle and connected to the vagus nerve in the neck. So it's kind of like and in a way similar to a pacemaker, but this is specifically for seizures. It sends electrical impulses to the brain to help reduce seizure activity. So what the doctors do is they can adjust the settings externally, and patients can even activate or deactivate the device using a magnet if needed. And this procedure is actually usually done outpatient. There are non-invasive ones coming out. I haven't seen it, but I was reading there are non-invasive versions of vagal nerve stimulation that are currently being developed and used and trialed, which is cool. So I recently did a travel nurse assignment on an epilepsy monitoring unit. I was very lucky I got the opportunity to do this. I had never done it before, worked on this type of unit. So the purpose of an epilepsy monitoring unit, known as an EMU unit, is to use that continuous video EEG monitoring in a controlled setting to observe and analyze seizure 24/7. So common reasons, so this is if you guys are interested in working on an EMU unit, they have them in Georgetown, which is where I was in Washington, D.C. You only have 4 to 5 patients max, which is super nice. So common reasons are to confirm their epilepsy diagnosis, identify seizure type and origin, and assess if these patients are a candidate for surgery. So I'm going to show you a video that it's a very detailed video on what it's like to be a patient in the unit if you guys happen to be interested in applying, because they do hire new grads. Would anyone be interested in working on an EMU unit? I loved it.
Is that just with adults or kids? Or?
It's actually adults on that unit. I don't know why my internet's not working.
Welcome to the Epilepsy Monitoring Unit, or as most people call it, the EMU, at UT Southwestern's William P. Clements University Hospital on the 8th floor of the Orange Tower. This video will prepare you on what to expect during your stay in the EMU. You will be asked to arrive at the hospital at 7 a.m. on the day of your scheduled admission. Please make sure to shower and take your morning medications prior to arriving. The admissions process can take several hours, and we want to prevent any delays in taking your medications. When you arrive at 8 Orange, the unit secretary will assist you to your room. The nursing staff will greet you and connect you to bedside monitors to record your vital signs continuously during your stay. You will have several initial tests performed, including blood work, a urine sample, and an EKG. You will have an IV started so we can give emergency medications if needed. The nursing staff will review your medication regimen with you. We ask that you bring all home medications with you in their original bottles. Some seizure medications are not carried by the hospital. We will return any medications to your family member that are not needed during the admission. If needed, these medications can be securely stored in the hospital if family is unavailable. After your initial tests are completed, an electroencephalogram test will be performed. This test is called an EEG. The technician will connect 30 electrodes to your scalp using a very strong glue. Once the electrodes are connected, a member of the epilepsy team, usually a nurse practitioner or resident, will obtain a detailed medical and seizure history. It is helpful to have a family member or friend who has witnessed your seizures available. After your admission process is completed, the epilepsy team will meet with you and come up with an admission plan. While you are in the EMU, there will be 2 cameras continuously monitoring the video and audio in the room. This data, along with your EEG monitoring and vital signs, will help the epilepsy team make their diagnosis of your events. You will likely be tapered off your seizure medications over the next few days with the goal of bringing about a seizure. Sometimes, stimulation techniques to induce seizures such as flashing lights, loud noises, hyperventilation, sleep deprivation, and use of bike pedals will also be used. Outside of testing, you'll be free to watch TV, use the Wi-Fi, and play games. You will be primarily confined to the bed or chair. Due to the risk of injury during seizures, you will not be permitted to walk in the room without staff assistance and the use of the ceiling lift sling, which will help prevent injury from a seizure outside of bed. These slings can go into the bathroom, allowing you privacy to use the facilities. Although cameras are on you 24/7 during this part of the stay, when going to the bathroom, the techs monitoring the cameras will change the angle of the camera to only show what is necessary and encourage your privacy while in the bathroom. You will not be able to shower while you have the EEG electrodes on your scalp, as this dislodges them, but heated wipes, fresh towels, and washcloths will be available for you to use. You can expect to have nursing do a neurological exam and vital signs every 4 hours. The epilepsy team will meet with you daily to review the plan of care. If you feel any symptoms like your home seizures, you and your visitors are encouraged to push your seizure button. The technicians monitoring you may also activate a seizure alarm if they see seizure-like behavior or activity on your EEG. Several nursing staff will respond to your room. Our staff are all trained to assess and assist you during a seizure event. For your safety, the bedside rails are padded and suction and oxygen are readily available in every room. The staff will ask you to describe what you are feeling and take you through a series of questions for the epilepsy team to review. The staff will communicate with the EEG technicians through a console in the room and describe what they see until the event ends. There are strict protocols in place that are followed to maintain your safety during a seizure event. We look forward to caring for you during your EMU stay. Thank you for choosing UT.
So our goal for these patients is to have seizures. So we want them to have seizures. So a lot of times with these patients, we are not even allowed to give Ativan unless it's been at least 5 minutes. We want to assess the seizure activity, what type of seizures they're having. So when I was on this unit for about 6 months before they forced me on another unit, it was so sad. I love this unit. But I never saw the tonic-clonic. I just saw a lot of the absence seizures when I was there. But yeah, this is a really interesting unit to work on if you guys find a position to apply for.
What do they mean by the bike pedal thing?
We didn't have a bike pedal, but they actually, a lot of times they purposely sleep deprive them, so they're not allowed to sleep the entire night. And they start drowsing, and we have to go wake them up, like, because we want them to seize. Super fun unit to work on. And there's a whole protocol when they have seizure. You have to time it. There's a form of questions that you go down the list and ask after.
Is that like directly after or after they're out of the postictal stage?
Direct or after the postictal.
Okay, gotcha.
Yeah.
So like when they're asking them questions, like, I mean, I guess it just depends on what.
It depends on the patient. Yeah, some of them can't answer. Some of them it takes time. Yep. So questions, practice test questions, and then we'll take our break before the next presentation. A nurse administered IV midazolam for a patient who recently experienced a seizure. Upon reassessment, the client's heart rate is 40, which is the side effect. Respiratory is 6 breaths per minute, and the client is difficult to awaken. What following information should the nurse implement?
B, C, and D.
Okay, you guys are fast. So, yes, we're going to administer oxygen, assess oxygenation status, and then administer that flumazenil. We're not going to give naloxone. That's not even for that's opioids. And then phenytoin, that's not something, that's for seizures, but not something we do for an active seizure right away. The nurse is caring for a client experiencing that tonic-clonic seizure. Which of the following appropriate nursing interventions will you guys do?
B, C, D, and E.
Yes. And why would you not do A?
Because they could break their teeth.
Yeah, so that, like I said, back in the day, people used to think they have to do this, but absolutely no. No tongue depressors. It'll cause serious injury to the patient and us as well. Can block their airway, of course. And then a nurse is performing discharge teaching for clients with seizures and a new prescription for phenytoin. Which of the following statements by the client indicates a need for further teaching? Someone say D?
Mm-hmm.
Yes. So one of the biggest risk factors for seizures is patients not being compliant with their medication. So you would educate on them. They cannot just stop taking their medication. A nurse is in the client's room when the client begins having a tonic-clonic seizure. What actions should you as the nurse take first?
B and D.
What did you guys say?
B and D.
So it's actually just, D, because we're going to prioritize those A, B, C's.
Oh, because it says actions. That's why I chose two.
When we're turning the client's head aside, we're prioritizing their airway. We do want to listen clothing, but that's not the priority. C's not even, we don't do that. We don't need to do that at all. And then we do want to document the time seizure began, but that's not our priority for the patient. A nurse working on a medical unit is caring for a client with prescribed seizure precautions. Which of the following interventions should the nurse include in the client's plan of care? What do you guys say?
A.
Yes, so of the 4, A would be the best answer. We're not going to place the client's bed and high. It needs to be low at all times. Again, no padded tongues available at the bedside. We don't even use those. The lights on an EMU unit, we do ideally want sunlight on to make sure we're assessing the patient at all times, but no, that's not our goal. That's not the priority. So we're going to obtain that IV access. A nurse is teaching the family of client with a new diagnosis of epilepsy about actions to take if the client experiences a seizure. Which of the following instructions should you as a nurse include in the teaching?
Just A.
Yes. We're going to make sure to move objects away from the client to protect from injuries. Again, no padded tongues. Don't ever restrain the client, and then never keep the client on their back for aspiration and choking risk. And then lastly, a nurse is caring for a client who ingested a poison is now experiencing a seizure. What is the following priority action the nurse should take?
C.
Yes, again, going back to those ABCs, checking the pain through the client's airways, the priority action, because maintaining a clear airway is crucial during a seizure to ensure oxygenation and prevent aspiration. So you guys are free to take a break. And then we'll start our next presentation.
Oh, goodness.
Yeah, but I didn't worry about it. Nope. That's not in the everything we tell you, but I try to help you guys focus.
What happened yesterday?
I did like it.
Oh.
I went to the
Yeah,
gym
yeah.
for like
So
the
I
first
think
time in
making
a
sure
while.
that important as possible. But my studying I have what I say is
I want to get this next Medsurg test out of the way so I can do my end of the year med math.
Yeah, I got you there.
I already did it for peds and OB. I can get a 60 and still pass.
No, I'm doing the same thing.
So like I used a lot of his advice and like his experience, and I didn't know how to reference it. So I put in quotations and then like what he said, because I put him as John Doe, but I don't like disclose his name obviously. Like a lot of this is from I found some of it from the book and another resource, incredible resource, but like again, it was his experience.
and that's good to know.
Like the diagnosis and that's what good for other than really long reading all the way through if you already
Yeah, so they do end up having to update. It's like a sticky. Well, I guess some hospitals do for different items, but basically they do cut a lot of you. Not necessarily all the stuff they have to say, but it depends on the patient.
So if you have like this, but if they have like
Yeah, they might have to.
Yeah, I know you did solid, like, girl, actually, so
Okay, guys, we're gonna present on headaches. Does anyone here suffer from migraines or chronic headaches? Anyone will relate to this presentation? Okay. So headaches may seem like such an easy and minute topic to discuss, but in reality, this is actually a really important topic. I have taken care of many patients specifically for headaches in the ER, on the medical units, throughout my nursing career. So my patients that are being treated for headaches, it's so debilitating that they literally can do nothing. They have to lay down in a hospital bed with their eyes closed, glasses, the lights off. These patients cannot do anything. That's how severe headaches can be for certain individuals. So you guys will expect to be seeing patients admitted for migraines. So headaches can be acute or chronic, temporary or life-threatening. This is a very common occurrence affecting people of all ages. Headaches are associated with other conditions such as colds, allergies, stress, muscle tension. There are two types of headaches. So there's primary headaches and secondary headaches are the two types. So with primary headaches, such as migraines, tension-type cluster headaches, occur without an identifiable structural or organic cause. And for secondary headaches, on the other hand, stem from underlying medical conditions such as brain tumors, aneurysms that do need to that require prompt intervention and evaluation. And then I will share my own personal story of regarding secondary headaches in my own personal life. So migraine headaches. What is a migraine? So migraine is a recurrent severe headache lasting 4 hours to 3 days. I've literally had patients in the hospital for like over a week just for migraine headaches though. So depending on the condition, I guess it can last a lot longer than that. But typically 4 hours to 3 days. So migraines often start on one side of the head. It may be spread accompanied by nausea, vomiting, like in the ER a lot of times. These patients are so nauseous with their migraines when they come in. They have to have IV nausea medications. They may be sensitive to light or sound. They can be preceded by an aura and are frequently followed by significant fatigue. So migraine aura describes these visual or sensory symptoms that appear just before the migraine begins. So again, not everyone has it, but it is typically common to have that warning aura before a migraine happens.
I get the aura.
Oh, you do?
Mm-hmm. It's like you start to see like your vision gets, the peripheral gets kind of occluded and like black and blurry.
Yeah, I found a video. I've never had an aura, but I have a video that shows what it looks like to your patient. Headaches tend to be common between, or migraines begin at puberty and peaks between ages 25 to 55. Typically more common in females and often have a family history genetic component. Again, the exact cause is unclear. A lot of times my patients with debilitating migraines, we don't know what's causing them. So these patients will be on in a specialty hospital on a neurology unit usually, because the doctors cannot figure out what is causing these debilitating migraines. A lot of times, they can be primarily linked to vascular disturbances. So migraines may occur with or without aura. Only 5% of adults actually experience auras. Of those, majority have visual symptoms such as flashing lights and blind spots. And then just in my experience of patients that come with migraines, I have had patients on PCA pumps because the pain is just so bad. So here's a video which I think is really important to be aware about migraine stigma. Because a lot of times these patients are underdiagnosed, they're not taken seriously. So it's something that we really do need to be aware of with our patients. Well, I don't have the link in here and it's not working. But, oh my gosh. Does anyone know how to play videos from the PowerPoints? Because that would change my whole life.
It just sometimes does not work.
No, it never works. It's so frustrating. So I can't, yeah.
The video usually just sits in as like a picture and plays, but
yeah, it works at home, but not here.
Yeah, I hate that.
So, anyways, basically, migraine stigma stems from the misconception that migraines are merely headaches. Let me go back to this. And excuses for poor performances. This misunderstanding leads to shame, delayed treatment, and social isolation for a lot of these patients. They're not being taken seriously by their doctors. Because it is an invisible condition, again, it's often dismissed and negatively affects these people's lives. So, migraines with aura. This is the classic migraine. Again, an aura is a set of sensory disturbances, most commonly visual. This occurs shortly before or during a migraine attack. It serves as that warning sign. So there are stages for these migraines with auras. So stages of migraines begin initially with that prodromal stage. These are the stage that has the early warning signs. They appear hours to days before the headache begins. Irritability, mood changes, food cravings, digestive issues, and frequent urination is part of this classic symptoms for the stage. Second stage is the R stage, develops over minutes to an hour, involving neurological symptoms such as tingling, numbness, confusion, visual disturbances such as flashing lights, and then leading to that second stage. It's at the stage where there's a severe throbbing headache that builds over hours, often with severe nausea, vomiting, drowsiness, and vertigo. Second stage turns into that third stage. This is the stage where that pain becomes a dull pain. In older adults, the aura may still persist even as the pain lessens. And then lastly, that recovery stage is when that pain and the aura fades away. The muscle soreness and fatigue are very common after, and physical activity may actually worsen symptoms. So the best thing for these patients is to sleep and rest in this recovery stage. So this is what an aura looks like, and it's cool because I had never even seen this before, so now I know what my patients are seeing.
You'll still live the life you chose for yourself.
I had ad block, but I don't know if they take it off. That's why. Frustrating.
Ad block for me
A
usually
larger
works
cause.
in between a video, but then I'll still always get the ad at the beginning.
Yeah, I put it on here, and I guess I don't know what happens. It just gets taken off. Okay, so this is what an aura looks like for patients that experience these with migraines. I guess maybe seizures as well. Is that what you were describing? Was that?
Yeah. Except for me, it's more like black.
Oh.
Yeah.
Yeah, so this is what your patients are seeing,
Yeah, that's it right there.
what you may be seeing.
That's exactly what it's like.
Wow. So now you guys know, because I had never known what this looked like before. Just
And I
know the
know it's
description.
Time to lay down and put a hot compress on my head.
Yep.
And try to fall asleep before the pain hits.
Yeah. Okay.
Do you want us to know the descriptions of all the stages for the test?
Be familiar, but it may not be on your test, but just be familiar with them.
Okay.
Yeah. So migraines without auras are known as the common migraine. These often occur in early morning during periods of stress with premenstrual tension or fluid retention. So these migraines without aura typically present as on one side of the head, so unilateral, pulsating headaches lasting 4 to 72 hours. Physical activity worsens this pain. Symptoms may include sensitivity to light, sound, nausea, and vomiting. So there are typical migraines. There's three types. There's three categories. So a status migrainous is a headache that lasts longer than 72 hours. A migrainous infarction is neurological symptoms persist for over 7 days and may show ischemic changes on imaging. So this is a rare complication of a migraine that does involve a temporary blockage of blood flow to the brain and can result in ischemic stroke. And then there's unclassified migraines, which don't really meet criteria for standard migraine categories. So it's just an unclassified, undiagnosed type of migraine. So risk for those migrainous infarctions are patients with clotting disorders, extremely high blood pressure, tend to be more common, vascular issues. So to manage acute pain, we as a nurse need to prioritize comfort for these patients through medication, elevating the head. We're not gonna keep the bed flat. It actually helps patients to elevate their head of the bed, and have a cool, dark environment, very quiet environment. Ideally, we don't want these patients to have roommates. I had a patient recently at Frederick Health with migraine, and she did have a roommate, but the roommate was so respectful. I felt bad for the roommate because she couldn't play her TV or anything. She had the lights off all the time. So ideally, we want them to have their own room. So how are we assessing these patients? So clients with migraines will experience photophobia, phonophobia. So phonophobia is that irrational, persistent fear of sounds or noises, and then photophobia is that abnormal sensitivity to light. They're going to have nausea, vomiting, stress, anxiety, that unilateral pain, often behind one eye or ear. Migraines do disrupt and interfere with this patient's daily activities, so they really cannot do much for themselves at all. So we need to be providing a lot of care for these patients. Treatment of migraines. So the treatment, there's a treatment called abortive therapy. So what that is it's a treatment used to stop or reduce the severity of a headache or migraine at its earliest signs. So we want to prevent that migraine before it happens. Abortive therapy aims to relieve migraine pain taken during that aura phase, if they have that aura, the trigger warning aura phase, or at the onset of headache symptoms. So for mild migraines, we're going to give NSAIDs, Tylenol, some over-the-counter migraine medications. For severe migraines, you're going to be giving these to your patients in the hospital. Triptans, sometimes they're IM medications. You have to give ergotamine with caffeine. Helps narrow blood vessels and reduce inflammation. Isomethactine combinations, these relieve migraines and severe tension headaches by narrowing cranial and cerebral blood vessels, reducing that pain triggering stimuli. So it's also very common to see antiemetics for patients with migraines as well. So a lot of times you'll get migraine cocktails, there will always be an antiemetic given with it. They're going to treat the nausea, vomiting associated, but also so Raglan is given because it specifically helps to increase gastric motility, improves absorption of oral pain relievers, and the triptans. So Raglan you're going to see a lot of time for these patients.
Oh, really? I did not know that.
Preventive therapy. Oh, yes.
I have a quick question. For migraines, do you ever see patients that get Botox? Because I have a coworker, she says she gets a Botox.
I've heard of it. I was just going to go over, that's next line is the Botox. But yeah, that is a treatment for migraines. Yeah. So preventive therapy includes NSAIDs that are combined with beta blockers can help. You'll see like calcium channel blockers, and then those anti-epileptic medications can also help, like topiramate is a very common one that I've given for patients with migraines. Of course, we need to educate these patients when receiving the blood pressure medications to monitor their pulse and blood pressure. Oh, sorry.
There's a medication called Furacet that I remember that I had a client with chronic pain in the hospital that he got for headaches, but that has like a bunch of other stuff and caffeine in it.
Yeah, it has caffeine. It's also known as I can never say this, butabidol is like the other.
Yeah, it's that one, and then it's like acetaminophen, caffeine, and then that.
Yeah, so that's a very common, that's actually considered a controlled substance as well.
Yeah, it's like it's like but essentially, if there's ones with beta blockers, is that to? I'm trying to understand, like, so it's one to like lower the blood pressure, but then there's one that like is better with increased vasoconstriction.
Yes, exactly. So that's why it helps. So it vasoconstricts those vessels.
Okay, so it's just reducing blood flow.
Yes.
Essentially.
Mm-hmm.
Okay.
Yeah, Furacet is a very common one. So Botox is FDA approved for migraines, also known as the anabotulinum toxin A, but that's Botox, so you don't have to worry about that name. It is injected into specific head and neck areas. It is administered over up to 5 treatment cycles. So basically this diagram just shows how Botox treats chronic migraines by blocking nerve signals to muscles, causing them to relax. You don't have to go too crazy about that diagram. So complementary and alternative therapies, including, we're gonna be dimming those lights, elevating the head of the bed. We're gonna refer patients at home because we really wanna try to get their migraines. We want them to live a normal life. So we wanna, at home, show them yoga, medication, Tai Chi exercise, class offerings at community centers. Biofeedback and massage therapy helps with relaxation, muscle tension release. A lot of times, where I'm from at least, they have free yoga classes, so you don't have to pay anything. It's once a week. They say donations are accepted. Donations if you can. But for a lot of patients that don't have money, maybe you can help them, show them about free classes for yoga and meditation, if possible. I don't know if they have that in Frederick. Biofeedback helps reduce headache frequency and severity by teaching patients to control physiological responses to stress, such as muscle tension and skin temperature. Acupuncture and acupuncture therapy for potential pain management benefits. So acupuncture is known to help by inserting fine needles at specific pressure points. Has anyone had acupuncture done? I've never had it done. Does it help? Some people swear by it, but basically the needles stimulate the central nervous system, triggers releases of endorphins and other natural painkillers in the body, those endorphins, and then it also improves blood circulation and helps reduce inflammation. There are herbal remedies, but we have to educate patients to be very careful about that and tell their doctor if they are taking herbal remedies. I was going to show you this behavioral therapies for migraines. I don't think we have time. But it's just good to know these alternate therapies for your patients, even if you have loved ones suffering from migraines. So how are we educating these patients? So we're going to provide guidance to prevent, minimize, and effectively manage migraine episodes. So as nurses, we need to educate on migraine triggers, avoidance, and management. So we're going to educate about dietary triggers. These are tyramine-rich foods, such as pickles, caffeine, beer, wine, aged cheese, and artificial sweeteners. MSG and preservatives and processed foods are also major triggers. Medications can trigger migraines, such as estrogen and nifedipine are common medications that can trigger. We're going to discuss emotional triggers such as anger management, conflict resolution for these patients. Lifestyle adjustments, so we're going to educate on adequate rest and sleep. Tell our patients to be cautious with travel involving altitude changes that can trigger severe migraines. Again, avoiding light glares, flickering lights, tracking those menstrual cycle patterns and hormone fluctuations. And lastly, we're going to avoid strong odors, perfumes, and tobacco smoke. That can all trigger migraines. So key migraine self-care monitoring tips for our patients include tracking headache patterns and triggers using a diary. We're going to have them report any changes in headache intensity or new visual or neurological symptoms to their doctors right away. Have them rest in that cool, dark, quiet environment. Again, elevate the head of the bed. And females over age 50 do have an increase of cardiovascular disease and stroke with frequent migraines. So we need to educate them to monitor these stroke symptoms to know what the stroke symptoms are if they happen to have them. This is a really interesting diagnosis that I had totally forgot about until doing this presentation. So cluster headaches, also known as trigeminal autonomic cephalgias, but they are known as cluster headaches. This is a rare but extremely painful type of headache that strikes one side of the head and comes in repeated attacks or clusters over weeks or months. So key features associated with cluster headaches include that they occur most frequently in spring and fall, so you guys take note of that. They are more common in males aged 20 to 50, something to take note of. Less common than migraines, and they typically have no warning signs. So associated, I thought I had a picture with this, but I don't know where it went. Associated symptoms of cluster headaches include drooping eyelids and eyelid sweating. So meiosis, they're going to have people constriction. Facial pallor or flushing, they're going to have bradycardia, so low heart rate, and nausea and vomiting. These patients are going to be extremely restless. They're going to be pacing, walking, they're going to be rocking if they're sitting down. Again, what age is most common, you guys, for cluster headaches?
20 to 50.
And then what season is?
Spring and summer.
Yes.
Spring and fall, yeah.
Spring and fall. So I was going to watch a video. I don't have time for that. I have 2 videos on this. So how are we assessing cluster headaches? Again, brief, intense, unilateral, it's a non-throbbing pain, but it's a very sharp, acute pain, but non-throbbing. It can last 15 minutes to 3 hours. Pain may radiate to the forehead, temple, or cheek. It can occur up to 8 times daily, so 8 times a day. Again, often in clusters, followed by remission. Hours are not present in cluster headaches. Symptoms on the affected side, so these patients are going to have tearing, runny nose, nasal congestion, facial swelling. They're going to have that drooping eyelid or eyelid sweating, as you can see in that picture. Meiosis, again, bradycardia, restlessness, nausea, vomiting. And this is a really interesting video that I want to show you guys. Oh my gosh, where are my links? Oh gosh. So yeah, this accurately describes what a cluster headache is in this news video, and I really wanted you guys to see it. Something is going on with my,
Dream Hair, real results. Let's start.
oh my gosh.
It is one of the most painful experiences that a human can endure.
It feels as though somebody is grabbing your inside of your face and pulling as far out and as far wide as they can.
Difficult to watch, often unbearable to experience. The pain of a cluster headache can be indescribable. Some sufferers post videos showing an attack to try and convey the reality. We're using these with their permission. Scott has suffered them for 10 years. He helps run a support group, Ouch UK.
I have knocked myself out on various occasions because of the pain. I will find something very, very hard to strike my head against, and because you're driven, it's a primeval driver to stop the pain.
Cluster headaches baffle doctors. Far more intense than a migraine. Many sufferers, like Rachel, experience them when seasons change.
I will get mine every spring and every autumn without fail.
Rachel's volunteered for a new research project taking place at King's College Hospital in South London.
We're looking to see what happens in the brain during the attacks compared to when there is no attack.
Around 40 sufferers will have their brains scanned.
This is the posterior hypothalamus, and it's also known as the internal body clock. We think that is linked with the cluster headache attacks. They tend to have more cluster attacks around spring and autumn. We don't quite understand the reason behind that.
This will be an ambitious, at times arduous project. Volunteers will also be having their brains scanned whilst an attack is taking place.
Unless people put themselves forward to things like this, we're never going to know any more about cluster headaches.
It's estimated there are around 130,000 sufferers in the UK, possibly more as the condition is often misdiagnosed. This patient, who's asked to remain anonymous, is being injected with steroids and an anaesthetic, a preventative measure that can help, but is only effective for a few weeks.
It's supposed to damp down the activity of the nerves, hence give some relief to these patients.
It's hoped this device, which would be implanted inside a patient's head, could offer long-term help.
The way it does is by delivering some electricity around the nerve and damping down the hyperactivity, the excessive activation of the nerves, which is firing without any control.
Trials are going well. The team at Guy's and St Thomas's Hospital hope to make it available within a year. A long-awaited...
Yeah, so I just thought that was a really good visual what these patients are dealing with. So how are we going to manage these patients? So they're similar management to migraines. Again, rest in a cool, dark, quiet room, elevate the head of the bed. Oxygen therapy actually can help the cluster headaches. Again, encourage regular rest and sleep, dietary guidance, avoid those foods that we discussed recently in the last slide. Oxygen therapy, medications used will again resemble migraine management, and then oxygen therapy at 12 liters per minute for 15 to 20 minutes at the onset of symptoms that relieve pain within 15 minutes.
Does it happen no matter? Oh, I'm sorry.
Oh, no,
Somebody else out there. Does it happen no matter where people live? Like, what if you live somewhere where it's like pretty, the climate is?
I think maybe that's why the UK, because it is generally that dreary weather majority of the year in the UK.
I was just gonna say, why not like move to Florida?
I know. Yeah, that would help.
That's a good point.
That would help those patients for sure.
Maybe Greece.
And this is just reiteration of what I discussed for client education. So I was going to have you guys watch this. It's not a big deal that we don't have time, but so I wanted to share my personal story with my twin brother. Going back to the secondary causes of headaches, he had an AVM, arterial venous malformation. It's genetic, actually, and a lot of times people are born with this in their brains. And no one knows they have it. You don't. It goes undiagnosed until it ruptures. So AVMs are a tangled cluster of these abnormal blood vessels. If ruptured in the brain, it leads to stroke, brain damage, or death. AVMs actually can occur anywhere in the body, and again, most are present at birth and remain undetected. Approximately 1 in 100,000 people do have this. So why headaches should never be ignored. So this is my twin brother at the age of 10 in the ICU, the PICU, UC Davis Medical Center. We're in California. So when he was 10, he did start having frequent headaches. Took him to the doctors, and the only thing they said was to have a headache journal. They wouldn't scan him. They said it was more harmful to scan kids at that age. So they wanted to initially start with a headache journal. Just weeks later, he was sitting in class and he just collapsed in his chair, looked like he was dead on the ground. So it turned out he had that AVM and had ruptured, causing extreme massive bleeding in his brain. If he was sleeping when this happened, he definitely would have died, and if no one was around. So thank God it did happen during the day. So he was airlifted to UC Davis Medical Center. Thankfully, one of the top hospitals in the country, especially for pediatric care. So me and my family lived at the Ronald McDonald House for it was over 2 months, because he was in the hospital for over 2 months for this. He was in a coma, had to have at least 3 different brain surgeries, eye surgeries. We were told he wouldn't survive, but the hospital did save his life in the end. Watching the nurses care for him, I just wanted to know every single thing they were doing. I have to know what you're doing. I want to be able to take care of my own brother. So that is why I'm a nurse, just from him being in the hospital. years later, ironically, I did end up working at the same hospital because my husband chose UC Davis out of all the schools he got accepted. He chose this hospital to get his immunology doctorate. So it's just funny how life comes full circle. I was working at the hospital for 6 years until moving here.
What type of twins are you?
Fraternal. Yeah. So that's my brother. That's his, our family. We made it our family dog, canine companion. He was actually bullied when he went back to school a year later. And he was in denial. He's like, I'm not disabled. I don't need a disabled dog. So we had that dog for 16 years. But, so this is him with me and my sister in recent years. So he did survive. To this day, he does live with hemiplegia, which means his entire left side is paralyzed. So even though he's completely paralyzed, he lives a normal, independent life. He has learned to adapt. And then he is a part-time accountant and a full-time volunteer because when he had his stroke about the hemorrhage, he said this to my mom when he first woke up. He said, I saw God talking to me, and he said, if you're going to survive and you're going to live your life serving people. And he literally lives to that since this day. So he works full-time as a community volunteer and an accountant part-time. Super smart. He's very good at math and all finances. So after everything's endured, I truly believe anything is possible. He remains one of my greatest inspirations in life. And this is the reason why I speak about headaches. Because what started out as just a headache nearly cost my brother his life. So chronic or unusual headaches are not something to shrug off. If your doctor isn't taking you or your loved ones seriously, seek a second opinion and advocate fiercely for your loved ones.
Hit them with the cuss.
Yeah, so that's my story. So I don't take headaches. I take headaches very seriously after that situation. Do you want to have any questions?
So, like, if they did the CT, they would have caught that.
They would have
aneurysm?
found it
Yeah.
within CT or MRI.
Crazy.
Yeah, and I didn't know this till recently. My uncle actually had an avium in his arm when he was a baby. So yeah, it's genetic, and it can happen anywhere in the body.
What
So
happens?
Is that something that you would get tested? I mean, I guess you can't.
I
do the
hope
whole
I
scan.
think they did brain scans with me too.
They did.
Yeah, so thankfully, but yeah.
What happens if it ruptures in your, like if you have one in your arm and it ruptures? Like what does that do?
It's not as dangerous, but you're gonna. I mean,
it just like
it's still you need to seek treatment right away. But,
hemorrhage under the skin type of thing?
but it
Under-
can happen in the brain, heart, spinal cord, anywhere. But yeah, secondary cause of headaches. That's it.